Cirrhosis is a major cause of morbidity and mortality in the United States and around the world. In the U.S., it's the 12th leading cause of death, with over 27,000 deaths per year. These numbers are definitely going to increase because of the hepatitis C epidemic in the 1970s and 80s. These patients are getting older and will be more and more presenting with advanced liver disease. So by 2020, it's estimated that the number of cirrhosis deaths will increase by 180%. And by 2030, we will be seeing a lot more cases because of the obesity epidemic that we're now experiencing. So cirrhosis is going to be with us for a long time. Now, it is progressive unless the underlying cause is treated, and that's always the most important thing, is to treat the underlying cause. And there's some pretty exciting data showing that if you do that, cirrhosis can be improved or in some cases reversed. So it's a more dynamic process than previously thought. Cirrhosis is generally divided into two stages, compensated and decompensated. The compensated patients often don't know that they have the disease. Their lab results may be normal. They usually feel well and have no complications. Decompensated cirrhosis is associated with all of the complications listed on the slide and about which I will be speaking today, and the overall prognosis decreases as the patients advance and get sicker. There's only one definitive treatment for cirrhosis other than treating the underlying cause, and that's liver transplantation. And as you know, the demand greatly exceeds the supply, so it's a struggle to get people transplanted. This slide shows the underlying cause of cirrhosis. The most common are alcohol, hepatitis C, and non-alcoholic fatty liver disease. Many of the others are common in the hepatology practice, probably less common in primary care. Chronic hepatitis B used to be more common, but there's now been 20 years of universal vaccination, so everybody 20 or under should be immune to it, and we're seeing mainly hepatitis B mainly in immigrants. Hemochromatosis is worth mentioning because it's more common than many people think, and many of these diseases do have a treatment, so it's always important to make the diagnosis whenever possible. Cirrhosis can be divided into stages, and these are shown here. It's very interesting that when people develop esophageal varices, there's only a very slight increase in mortality. But when they start bleeding, the mortality goes up to over 50%. So these stages can be useful. But there's one source of confusion that often occurs. When you see liver biopsy reports, you'll see the stage of fibrosis. And stage 4 fibrosis on a liver biopsy report is cirrhosis. So I've had patients come to the office in a panic saying, I got stage 4 cirrhosis. Really what they meant is they had cirrhosis and it's not necessarily so advanced. So that is a source of confusion, but one that causes a lot of anxiety for people. So esophageal varices are a very serious complication. Bleeding from these can be massive and sometimes fatal. I'm going to talk about primary prevention, which is prevention before bleeding occurs. There is also secondary prevention, which is preventing repeat bleeding after the initial bleed, because once you bleed once, the odds go up greatly that you'll bleed again. But I'm not going to talk about that because that's hospital management. When someone is diagnosed with cirrhosis, they should have an EGD to see if varices are present. And this should be repeated every 2 years for the stable patient and sooner for the decompensated patient as indicated. The treatment is with non-selective beta blockers, which are listed here, and larger varices are also treated, even if they haven't bled, with variceal ligation, and that's in addition to the beta blockers. So that's the treatment for primary prevention of esophageal varices. We'll spend a bit of time on ascites. Ascites is the most common cause, most common complication of cirrhosis, and about 80% of cases of ascites are due to cirrhosis. There are, however, other causes, cancer, congestive heart failure, TB, and others. So it's very important to do a paracentesis at the onset of ascites to pin down a diagnosis. When a paracentesis is done, the following tests should be performed, especially cell count culture, albumin, and cytology. The total protein and LDH are useful mainly in spontaneous bacterial peritonitis, which we'll talk about. A very useful calculation is the serum ascites albumin gradient, or SAAG. This is the serum albumin minus the ascites albumin. And this predicts with a very high reliability whether the patient has portal hypertension due to cirrhosis or the other causes. If it's 1.1 or greater, it's, the ascites is almost always due to cirrhosis. So that's very useful. In general, ascites is associated with a poor prognosis. It is an indicator of decompensation. It is associated with certain complications, spontaneous bacterial peritonitis and hepatorenal syndrome, that pretty much occur almost exclusively with patients with ascites. There's an increasing mortality, especially as the years go on, and if the ascites becomes refractory, mortality is about 50%. Again, the initial treatment is to look for the underlying cause. And I mentioned the three listed here, alcohol, hepatitis B, and hemochromatosis, because even if a patient presents with ascites and never even knew they had liver disease before, treating these three entities can result in a very significant improvement. So it's never too late to try to treat these problems, and sometimes you can have very favorable results. It's important in ascites to avoid nephrotoxic agents. These are important because there is altered renal hemodynamics in ascites and cirrhosis, and because we're going to be using diuretics, which also exacerbate renal dysfunction. So these drugs are best avoided. In particular, NSAIDs should be avoided in patients with ascites. The cornerstone of treatment is dietary sodium restriction. And none of the other treatments will work if this is not adhered to. Consultation with a dietitian can be helpful. Certainly the patients need to start reading labels and paying a lot of attention to this. Most of the time we need to use diuretics as well. We usually use the combination of furosemide and spironolactone. These two diuretics work on different parts of the kidney, and they have opposite effects with regard to potassium, so they balance each other out very nicely. These diuretics can all be given as a single daily dose in the morning. Doesn't need to be divided. And basic metabolic panel and weight, of course, need to be monitored. Fluid restriction is less important unless the patient has hyponatremia, when it becomes very important. But the real emphasis is on sodium restriction. Refractory ascites is not responsive to diuretics. If it hasn't been done already, certainly a liver transplantation referral should be considered at this point. The treatment is usually with large volume paracentesis. We give albumin during and after the procedure to prevent complications, mainly if 5 liters or more are removed. Again, it's important to check with these patients to make sure that they are complying with sodium restriction. For patients who don't respond even to regularly scheduled paracentesis, one option is a TIPS, transjugular intrahepatic portosystemic shunt, and this is very effective, but has a lot of complications of its own, and in particular may exacerbate hepatic encephalopathy. And many of these patients, by the time they reach refractory ascites, they have encephalopathy. So the use of it is relatively limited, but it can be very effective. Spontaneous bacterial peritonitis is a very important diagnosis to consider in the patient with ascites who has any type of additional symptoms such as fever, pain, altered mental status. It's very important to suspect this, send the patient to the ER, and let the ER know that that's what you're thinking of. The patients will usually need to be admitted and have a paracentesis and started on IV antibiotics. The paracentesis, of course, should be done before starting antibiotics. Ascites fluid culture should be taken in blood culture bottles. To make the diagnosis, we're looking for 250 or greater polys on the cell count. There are some other clues listed on the slide. Usually the treatment is with third-generation cephalosporins. The culture may be negative, but if the cell count is positive, treatment should be continued. Usually a 5-day course is adequate. Coming back to the office side, prophylaxis is very important. Anyone who's had SVP should have prophylaxis, and the regimens are listed here. There are certain other high-risk conditions shown on the slide, and those also benefit from prophylaxis. And the prophylaxis is continued until either they get better or they get the liver transplant. Hepatic encephalopathy can be overt or covert. Overt is clinically obvious, and they're very often precipitating factors. Those are shown here. Usually one of these, one or more, are responsible for the exacerbation. The other thing that's responsible is patients not taking their lactulose. That's probably the most common, actually. It's important to remember that other diseases can cause a similar syndrome to hepatic encephalopathy, and they are shown on the left part of the slide. The treatment of encephalopathy is with lactulose. We like to aim for 2 to 3 SARS stools per day and titrate the dose to reach that point, but often the symptoms persist and we need to go higher. Rifaximin is an excellent drug. It's oral. Patients like it. They don't like lactulose because it causes gas and diarrhea. But rifaximin is a non-absorbable antibiotic. It's very well tolerated and it is effective. The problem is it's very expensive and some insurance plans don't cover it. And in the days of high deductibles that we're all facing, many patients are just not going to take it. A poor man's rifaximin is nitazole, and possibly there may be some benefits from probiotics. A major issue in hepatic encephalopathy is to assess the suitability for driving a motor vehicle. These patients have a documented higher risk of motor vehicle accidents, and therefore when they drive, they're putting themselves and others at risk. This is one of the most difficult discussions that I have in my practice. When you approach this issue, it's very helpful, if possible, to enlist the family and get their support before really being very definitive with the patient. But there certainly are some patients that should not drive a car under any circumstances. That, of course, takes away their freedom and independence, so it's not well received. Now, just to make things more complicated, there's a syndrome of minimal or covert hepatic encephalopathy. This is clinically invisible. no signs or symptoms. It's seen up to 80% of patients. It can be diagnosed with psychometric or neurophysiological tests. It may affect worker driving performance. It can be treated, but the problem is there's no gold standard. There's no accepted battery of tests with a documented cutoff value distinguishing normal from abnormal. So we know it exists, and we're not really sure how to prove it. Some have actually suggested that all patients with cirrhosis should get lactulose. I'm sure they will just love that. So let's move on briefly to hepatocellular carcinoma. This is the 9th leading cause of cancer deaths in the U.S., and it is increasing greatly in prevalence. It used to be a rare tumor, and because of hepatitis C and to a lesser extent hepatitis B, more and more cases are being seen, and many more will be seen in the coming 10 to 20 years, again because of the aging of the hepatitis C population. Screening is with ultrasound every 6 months. So anyone with cirrhosis should have an ultrasound every 6 months. Alpha-fetoprotein is not recommended for routine screening. It could be useful for confirmatory evidence if there is a liver lesion, but it's not sensitive or specific enough. The diagnosis of hepatocellular carcinoma can be challenging at times. Usually it is made by contrast CT or MRI. The typical finding is enhancement on the arterial phase and washout on the venous phase. And if you have that in a patient with cirrhosis, a tissue diagnosis is not necessary. The findings are very clear. The treatment is ideally with liver transplantation. This can be done with 1 to 3 lesions. They have to be very small. If they're slightly bigger than the standard, they can be treated with interventional radiology and shrunk, and then the patient will be eligible for transplant. That's called downstaging. I would say that most of the patients of mine that have gotten transplanted in the last 5 years have been with hepatocellular carcinoma because they get extra points on their MELD score. But that makes it tough for all the other patients. It's a real problem. Interventional radiology techniques can be used for larger lesions. There's a slight survival benefit from the chemotherapeutic agent, sorafenib. And patients with very advanced disease, the best thing you can do for them is tell them to put their affairs in order, because it's a very lethal malignancy when it reaches the advanced stages. Vaccinations are important in patients with cirrhosis. These include hepatitis A and B vaccines, which are safe and effective. Now, you might think that the patients are at low risk to get these infections, and that may be true, but if they were to come down with hepatitis A or B with pre-existing cirrhosis, it would be very severe, if not fatal. So that's the real reason you're vaccinating them. Influenza and pneumococcal vaccines should be given. They are safe and effective in cirrhosis. And there's even evidence that influenza vaccination reduces the mortality in cirrhosis and reduces the episodes of decompensation. Varicella and herpes zoster vaccines are thought to be safe, but there's very little data. For all of these, it's desirable to give the vaccine during the compensated rather than the decompensated phase, but sometimes we don't have a choice, so a clinical judgment is made. It's always important not to forget to treat alcohol and drug addiction. These are problems that underlie much of the liver disease we see today. It's very important for the physician to be an advocate for abstinence. Patients should be encouraged to go to Alcoholics Anonymous or AA, and if they refuse, what I tell them is make your own AA. Go to a bookstore, buy some books on recovery, read them every day, and keep the mantra of one day at a time firmly in mind. We hope that they do that. Patients with opiate addiction should be treated with appropriate therapy, and counseling is important in all addictive diseases. Now, you might be thinking I mixed up my slides. Vibrio vulnificus is something you might have learned about in med school. It's a gram-negative bacteria seen in seawater, and it's the largest cause of shellfish-associated death in the United States. It has several syndromes, but the one that's important to us is primary septicemia. Now, this is associated with consumption of raw oysters in about 90% and other types of seafood. And it has a very high attack rate in cirrhosis, hemochromatosis, and other liver diseases. Apparently, this bacteria loves iron-laden cells, and that may be part of the reason that its death rate is very high in these patients. A bullous skin lesion may be a tip-off. There's a high fatality rate unless treated. So the bottom line for us, since we don't live near seawater, is that patients should, with cirrhosis, should avoid raw shellfish, especially oysters. I'm going to talk briefly on nutrition. This is going to be the last slide. Nutrition in cirrhosis. We don't recommend restricting protein in the same way as we did in the past. Patients with cirrhosis have a catabolic state. They often break down muscle. That's partly due to difficulty with storage of glycogen in the cirrhotic liver. So the liver will then go to gluconeogenesis, which is synthesis of glucose from amino acids. And so again, you're breaking down your own muscle, and you've seen patients with cirrhosis often have temporal wasting and complain of muscle weakness. So they need protein. Vegetable and dietary protein, vegetable or dairy protein is preferred. We still don't recommend that they eat a big steak. Patients should eat breakfast and have an evening snack of carbohydrates. And this is to prevent going into the starvation physiology with gluconeogenesis that I mentioned a moment ago. Antioxidants may have some value as probiotics and fiber also. There is benefit from branched-chain amino acids, and there are feeding formulas that utilize these, but they tend to be unpalatable and have a high cost, so we don't use them too much, and again, avoid raw shellfish. So that concludes my talk. We've covered the main complications of cirrhosis, the main interventions that need to be considered in the outpatient management of cirrhosis. Treating the underlying cause is always the best approach. We hope eventually to move into an era of prevention where we can focus more on preventing complications than treating complications. Something like what cardiology is doing.